Hey everyone, welcome back to the Vocal Pelvic Floor. Today I am joined by Dr. Lora Liu, an expert excision surgeon and passionate advocate for endometriosis care. We dive into the critical questions every patient should ask before surgery. This is a must hear, and the importance of a multidisciplinary team, and why proper diagnosis and treatment are still so hard to access. Dr. Liu also shares her unique path to becoming a surgeon and how her personal experiences shape the way she cares for patients. This is an episode packed with insights you don't want to miss. Let's get started. Hi, everyone, and welcome back. I am super excited to have a guest with me today who's doing incredible work in the field of endometriosis. Dr. Lora Liu, welcome.
Hi, nice to be here. Thank you so much for having me today.
Oh my gosh. Well, thank you for taking time out of your really busy schedule to do that, because I know endosurgeons, there's not enough. Okay. First, if there's not enough of you in the United States and in other places, and to just snag you for a quick interview is amazing. And while I've been thinking about this, you guys, before I introduce you and read the bio that I put together, because she's doing some amazing things, I think I finally figured, I was like, you have such a cool name. And it occurred to me why I was thinking that, because Dr. Lora Liu, it sounds like a superhero. A superhero. And then
You
I'm
know,
thinking,
everyone calls me Lucy Lou, and I'm like, you know what? I'll take it. I'll take it. I'm fine being called Lucy Lou.
Lucy Liu. And then, but it's not far off. You're a surgeon and a mom and all of these other amazing things. I'm like, it fits. She's a superhero. I'm going with that. Okay, so short bio, you guys. We'll put the full bio in our blog version of this post, which will have the entire transcript in it. So if there are links and things that you note in the podcast, they will be in the show notes there. All right. Dr. Lora Liu discovered her passion for laparoscopic surgery early, inspired by her father, which is a really unique story, Dr. C.Y. Liu, a pioneer in gynecologic surgery. Her interest in medicine solidified during college, where she double majored in biophysics and, two hands in the air, music, before pursuing a medical degree at Loma Linda University, which I think is incredible. Dr. Liu completed a year in family and preventive medicine residency at Loma Linda, but missed the hands-on work of surgery. So then she completed her OB/GYN residency at Northwell Health's Lenox Hill Hospital in New York City, and a fellowship in MIGS, or minimally invasive gynecologic surgery, at Mayo under renowned experts. Specializing in chronic pelvic pain and endometriosis, Dr. Liu collaborates with multidisciplinary teams to address the complex nature of the condition. She also emphasizes holistic post-surgical care, 2 fist pumps, partnering with physiatrists, pain specialists, pelvic floor, physical therapists to support her patients' recovery and quality of life. Welcome again.
Thank you so much.
So my first question is, as a fellow musician, is, oh my gosh, tell me about this musical background that absolutely, I think I'm a little biased, but I think it must just make you an even better surgeon and a better human being, actually. But tell me a little bit about it.
Yeah, so my mom started me with formal violin lessons when I was 3.5. And she tells me that I wanted to play the violin. I don't know if that's true because I just don't remember, but I feel like I have always grown up with a violin in my hand. My older brother, who's 5.5 years older than me, is also a violinist, and he actually went into music and violin as a career. So I think maybe she's telling the truth. I probably just wanted to do whatever my brother did. So,
Yeah.
I, like I said, I feel like I was born with a violin in my hand. And I continued that throughout college, and where I decided, oh, let me, if I don't major in music, then I'm never going to practice. That was kind of my rationale. Is like, it's
Yeah.
going to force me to practice. And so I did major in music, and also did the pre-med route. I also double majored, as you mentioned, in biophysics. But music has been just a huge part of my life, to the point where I was considering not going to medicine at all and just doing music full time as a profession.
Wow, that's incredible. Now I want to hear you play sometime.
No, you not now. It's going to sound like well, I mean, you're a string player, so if you
Oh my
take like
gosh.
one day, 2 days off, it's really not good. And I've
Yeah.
taken decades off, so it would be brutal.
It
Yeah,
must
no
be
one wants to hear that.
that's the kind of thing that is well, there are a lot of things I'm sure about practicing medicine that keep you humble, but also putting your instrument down, any instrument, and picking it back up again, it will keep you humble.
Oh, that's for sure. That is for sure.
Yeah. Oh my gosh. Well, shifting gears a little bit, I love your Instagram post. I don't really know how you have time to do that too, plus do all the other things that you do. But one of the posts that I love the most was the one that you had about top questions to ask your surgeons before surgery. So I was wondering if you could give the listeners just a, kind of a blow by blow of what was in that post.
Yeah, I mean, how long do we have? Because I could sit here for hours to discuss everything that you should grill your surgeon about before you have surgery, particularly when it comes to endometriosis. But I think some of the top questions is your surgeon a busy OBGYN? Meaning, does he or she still practice obstetrics, delivering babies? Because I think that says there. Listen, it doesn't say a lot, but I think it kind of gives you an idea of how their time is split. Because
Mhm.
if you're gonna have surgery, you want to do it with someone. At least I would want to do it with someone who just does that all day, every day, over and over and over again, because that means that your high volume, your complication risks are going to be, or your rate of complications are going to be less, as well as you're not going to be pulled in so many different directions as you are with obstetrics. I mean, delivering babies it's stressful. It takes a lot of time. They like to come at 3 a.m. in the morning. You're always kind of on, and it's extremely stressful. So I think that's probably one of the biggest questions, one of the top questions that I think if my family member was going to have surgery for something very specialized, I would just be like, what else do you do with your time? Or what
Mhm.
else do you do, not with your time, but in terms of working? How's your time split between surgery and everything else? So that's probably one of the biggest things. The second one is kind of along the same lines. You do medical management of medical GYN. Are you doing breast exams, pap smears, menopausal treatment, all which are completely fine. But again, like I said, it kind of gives you an idea of how their focus is split, or just kind of where they're choosing to spend a lot of their time, whether it's in the office or in the OR. Um, I don't know. I have a ton of other things as well. Multidisciplinary team, because we know that endometriosis can grow basically anywhere in
Mhm.
the abdominal pelvic cavity. And it's really important, I think, for your surgeon, or yeah, for your surgeon to be able to handle whatever they find when they're doing your surgery. And it doesn't mean that they specifically have to do everything, but they are prepared with either special, and it's fine if they can do everything, that's completely fine. But it's also important, I feel like, to have specialists who can also step in and take over. So if someone needs a bowel resection, is your surgeon going to be like, you had endometriosis in the bowel, I didn't feel comfortable touching it, and so you're going to need
Mhm.
another surgery, which is completely okay. If your surgeon doesn't feel comfortable doing something during surgery, then you certainly don't want them to do that. But I think it's always good to kind of be prepared and possibly have the general surgeon that they work with available to do that as well. That way you have one complete surgery, close that chapter of your life, and get on with
Yeah.
living. So you don't have to keep on coming back for more and more.
Yeah. And I think one of the things that you said really resonates with me because I have heard patients come back and tell me this many times, which is why as soon as they get to my office, I'm referring them out to one of you guys for actual skilled excision because they'll come in and say that they had surgery with someone, usually GYN, and the GYN went in, saw that there was endo in places they didn't know how to reach, weren't comfortable reaching. But the difference is they didn't then close them up and refer them somewhere else. They just said, we got what we could, and then sent them on their way as if that was enough.
Yeah.
Right.
Or better yet, say, we got what we could, but let's put you on some Lupron to take care of the rest of it. And that
Right.
I feel is even worse
Right.
because now you're just giving false information. I mean,
Yeah.
because
Yeah.
it's not going to go away with Lupron. It didn't go away, before surgery with all this other
Mm-hmm.
medical
Mm-hmm.
hormonal suppression. So,
Yeah, yeah, you just hit the nail on the head. I mean, that's unfortunately most of the stories that I hear, in my particular practice because we currently don't have anyone in our state, so
mm,
you've got to go out of state to do that.
yeah.
So yeah, so I get a lot of those stories. One of the other things that I love, you have such a public health driven background because you went into family and preventive medicine. How does that influence your work today?
Yeah, so I did a year after I graduated from medical school. I did a year of family medicine and preventative medicine. But as you mentioned, I missed the hands-on. I love surgery. I missed the hands-on stuff. And also, I just think I wasn't smart enough to know everything about everything, which family medicine docs need to know. But it did give me a really good baseline in terms of looking at the whole person. It's not just let me just focus on I think a lot of times with medicine, and this is a good thing and a bad thing, but everything is so subspecialized now.
Mm-hmm.
And we're just trained, and I'm very subspecialized. I tell my patients, look, I'm a one trick pony. I just know how to do endometriosis surgery, and everything else I'm going to have to refer you out because I'm not smart enough to know about everything. And frankly, I'd be doing a disservice if I tried to do everything. But I still try to look at the patient as a whole person, and not just treat the disease, but also treat the person and understand that my role in this patient's journey is it could be a very small role or it could be a very big role. And if it happens to be a very small role, who can I set my patient up with to make that patient whole again?
Mm-hmm.
It's very easy to cut out disease. It's not so easy to undo decades of medical trauma, of physical trauma from
Mm-hmm.
just, being in pain every single day for decades. A surgery doesn't fix that. And I am very confident I can get out the disease, but am I able to really restore the whole person to, well-being? I don't, a lot of times I can't. So I
Yeah.
think that's what family medicine has taught me is to look at the whole person. It's a person, it's not just a disease.
Yeah, and it underscores the importance too. Maybe you're listening to this podcast for the first time, and this is the first episode that you have dropped into. I think one of the biggest take homes is that endometriosis feels like a full systems threat. It's like a full systems,
Yeah.
body systems disease, and there are too many practitioners and people. I think we have a health literacy problem still, not just in general, population and people, but also in the healthcare world where they don't understand what a full, body impact endometriosis has,
Yeah.
and that is one thing that's so important because to your point, from my end, what I see is someone comes in and all the tissue that I'm going to work with from a pelvic health perspective didn't get the memo that things were
Yeah.
fixed and cleaned up,
Right.
So maybe you had snarky psoas like hip flexors, a respiratory diaphragm that was impaired because it can be in the respiratory diaphragm. And then from the respiratory diaphragm, that impacts, intrinsics of the vocal cords and how people speak, since those are connected. I see all of those and they present all of those things, those tissue issues, if you will. And it's almost like one big trauma posture. Like if
Yeah.
you think about how someone is curled up in a ball when they're really upset or they're crying or they're in pain all the time, it's just like we have to unwind all of that trauma posturing that happened. And usually it is over decades. It's not
Yeah.
just, unfortunately, because of diagnosis, delays in diagnosis. It's been a good long time since they weren't gaslit, right? When they see you, hopefully that's the beginning of the end of their gaslighting, regarding endometriosis. But then we have to convince all the tissues that that's happened too.
Yeah, I love that. They didn't, the tissues didn't get the memo
No.
that endometriosis is no longer there. They didn't get the memo. So I love that actually.
Yeah, they present with all kinds of things like deep hip pain,
Oh
deep
yeah.
pelvic pain. Obviously, that would be a go-to, but also hip pain, where someone may have told them, "Oh, yeah, yeah, it looks like you have a hip labral tear. You could be a candidate for hip arthroscopy."
Yes.
And they come in, and it isn't that actually. It's just that none of the deep hip rotators or the gluteals, nothing is working anymore. Everything's too busy, curled up in a ball, and
Yeah.
it's all hip flexors and no, what we call posterior chain. And once you get those things, I call it pressing the reset button. Once we can
Hmm.
press the reset button and the tissues are like, wow, this is a brand new day. This is how we are to act. Then it can help people avoid misdiagnosis in other ways too. So
Yeah.
yeah, that holistic approach is just so incredible. I think that another takeaway too is that, to speak to the expertise of what you do, I think a lot of people will go in and surgery, excision surgery, skilled excision surgery is the gold standard, right? It's the gold standard. But I think that people may underestimate the healing time and the
Yeah.
recovery, that it takes, so that 6 weeks later they're like, well, I don't feel any different. Well, hold up.
Yeah.
The surgery was a success.
Yeah.
Right? Is a lot of education, and I think this is a great platform to then kind of walk them through a little bit of that process of how long, when you see your patients and then you're following up, how do you follow up with them, and what are some of the things that you hear that will make people feel better about, okay, I don't need to panic if at 6 weeks I am not feeling as I should, because that it could take that long to get in with their pelvic PT to start PT anyway.
Yeah, no, 6 weeks is just this arbitrary number that I think we've just been taught in medical school. It's okay, post-op recovery, 6 weeks, and you're good to go. I mean, same thing with delivering a baby too.
Postpartum,
Six
yeah.
weeks and you're good. And you're like, nope, I'm not good. I'm completely destroyed at 6 weeks. I can barely. It's the same thing. Like
Yeah.
6 weeks, there's no magic, nothing magical happens at 6 weeks. And for some patients, yes, they are completely fine at 6 weeks and good
Hmm.
for them. I will say that it isn't, they're the minority.
Yeah.
That is not generally what I see. I will say, look, after like 4 weeks, you can start lifting, things heavier than 10 pounds, blah, blah, blah. Your incisions are going to be completely healed by that time. And so, yeah, you may look fine and you may be able to lift things that are heavy. You can still, you can go back to work, but you are still healing. And sometimes it can take, and a lot of feedback that I get from my patients. And again, my patients have been my best teachers, because when I first started, I was saying, yeah, 6 weeks, you're good. 6 weeks, no problem. 6 weeks post-op check, come in, thumbs up, have a nice life. And a lot of times patients are feeling better at 6 weeks, but the recovery can last 3 months, 6 months. Some
Hmm.
patients said, look, I didn't really even feel great or really begin to feel quote unquote normal until like 9 months.
Yeah.
And a lot of it depends on the individual patient. And I mean, so much depends on that as well, but also their care team. So I know we were initially taught, or I was initially taught, don't do PT for 6 weeks after surgery. And I'm like, I tell my patients, look, once you feel like you're up to it, go see the PT. I've had patients
Yeah.
go, I told a patient last week, she emailed me at like 4 in the morning. It was 2 or 3 days post op. I said, please go reach out to your PT.
Yeah.
Um, And she got in with her PT 3 days post-op and said that was the best thing ever. She's like, I
Yeah.
feel amazing. And so I think, again, it depends on the PT as well. Not
Yeah.
all PTs are created equal. Not all surgeons are created equal. Not, everyone's an individual. But I tell my patients, look, go back to PT as soon as you feel up to it. There's no restriction, especially if you've had, now, if they've never been to PT before, I tell them maybe wait a couple of weeks just because I don't, you may not, it may not be the best to do an initial eval so early after surgery. But if they've had a relationship with the PT, I'm like, please go, like as soon
Yeah.
as you want.
I think you brought up two really important points. And when I am seeing a patient, I always want to, usually I'm referring them out, to begin with, because they haven't had excision surgery, they had ablation, or they need to see you. That affords me the ability to, and it impresses, it brings up the importance too of seeing a pelvic PT would be ideal at least once or twice before you go
Before.
in.
Yep.
Because then you can prepare them, for
Hmm.
what comes after. And also it tamps down a lot of the fear too. If they have that 2 or 3 day post-op, they're like, oh my gosh, I'm in particular types of pain. I think it's the pelvic PT's job to go, these are the types of pain. Here's to differentiate, here's how you differentiate between the types of pain. It could be gas pain. It could be constipation pain. It
Yeah.
could be incisional pain. And here's what you do for each of those things. And that actually cuts down on probably the number of calls your office is going to get too, worrying about
Yes.
different types of pain. And then they're less fearful too. And because if they're fearful, there goes the trauma posturing, and there goes all the muscle, the tissue issues. The pelvic
Yep.
floor begins to tighten, and that does not feel good, post-op. So that's I think one thread I wanted to pull out of what you said, because there's just a lot of pre and post-op stuff that can be just, everybody wants to feel like um, they're attended to and that their pain is believed and heard. And if they can understand ahead of time the half a dozen different types of pain and what to do about it, they feel
Hmm.
pretty empowered too,
Yeah.
going
Yeah.
into it. And that brings up one more point you said, which is the support system. I would love to hear what you might say to patients and their caregivers. Maybe it's speaking more to the caregivers than the people with endometriosis right now. But because the incisions are so small, it's not this
Hmm.
big open surgery anymore. I think that a lot of family and well-meaning caregivers think that they're just going to be up and going in 2 weeks, or even the magic 6 week, the non-magical 6 week mark.
Yeah.
And that can create a lot of like self gaslighting, where a patient feels like, well, I should be, because
Yeah.
they have this fill in the blank, doing fill in the blank, because my family feels like, well, what are you laying around for? You just have these
Yeah.
tiny little incisions. Anyway, what would you say to those caregivers and patients to really prepare them for that?
Yeah. I mean, to your point, unfortunately, we're able to do these big surgeries through little tiny incisions, which is amazing because a few years ago, I mean, not even a few years ago, patients are still getting big incisions to take out their uterus, right?
Yeah.
And anyway, but a lot of surgery happens on the inside through those little tiny incisions, and but you just don't have the battle scars, I guess, to show for it. And those incisions are 8 millimeters. They're 8 millimeters. They're extremely tiny. They heal very quickly. And because it is done minimally invasively, the majority of my patients do go home the same day. I'm like, you have to get up and walk. Walking is the best thing, upright, moving around. But I always say, look, you're going to be extremely tired because a lot of surgery happened on the inside. And the way that the body recovers is by forcing you to rest. So you have to take nap. You are going to be extremely tired. You're going to be fatigued for months after surgery. It's not just a couple of weeks, it's months. You're going to have fatigue. Even if you feel good and your pain is pretty much gone, you're still going to be so tired. You're going to go to the grocery store and you're going to have to take a nap when you come. Yeah, so you're going to feel fatigued for weeks, months after surgery, even if your pain is pretty much gone. The surgical pain is going to be gone, but the fatigue lingers. And I think it's important for not just the patient to realize that, because I think a lot of times, like you said, endometriosis patients are so good at gaslighting themselves and being like, well, I should be feeling this way. I shouldn't be in pain. Everything's negative. And it still continues after the surgery. I should be up like running a marathon. I should be up like taking my kids to school. I should be doing PTA. I should be back at work. Because my incisions look fine. They're healed. I barely have
Mhm.
any scars. But that's just not the case. So much surgery happens through these little tiny incisions. I mean, basically, every single organ in the abdominal pelvic cavity can be operated at, during the course of a 4 or 5 hour surgery. And that takes time. That
Yeah.
takes time to heal. It's something that I try to reiterate with my patients, because I hear a lot of shoulding from
Mhm.
patients. I should feel this way. I should be doing this. I should be back at work. I should be, taking care of my family. I'm like, you got to take care of yourself. You got to take care of yourself before you can take care of anyone else. And you had a big surgery, and you have to recover. And
Yeah.
if you don't recover, your body will force you to recover and rest.
That's true. That's true. Yeah, there's a quote: if you don't make time for wellness, and you can insert any wellness,
Yeah.
fitness, self care, then your body's definitely gonna take time for illness.
Yes. Yes. It will force you to.
Yeah. Well, I mean, along those lines, I mean, with your dad being, at the forefront of gynecologic surgery, and you must have some stories and a lot of influence, for you to end up where you are. Just take us down that memory lane a little bit.
Yeah, so my dad was a GYN surgeon. He was one of the pioneers of GYN laparoscopy in the United States back in the late 80s, early 90s.
Wow.
Him and Harry Richard, I think, one of the first in the country. So I just remember at a very early age, and I actually saw my dad this weekend and we were talking about it. He's like, "Oh, you weren't that young." I'm like, "Dad, I promise I was very young when I would come to the hospital with you." He's like, "Really? I don't remember." I'm like, "Well, you're old and your memory's no good anymore." I remember. So I remember going with my dad to make rounds. And then once I was old enough to go into the OR, which I don't know if there was really any criteria, but I guess as long as he knew I wasn't going to contaminate the sterile field, he took me into the OR. And at that point, he was doing laparoscopy. So I could just watch it on the big screen. I could just watch TV basically. And I just thought it
Yeah.
was so cool. I loved it. My older brother, like I mentioned, is a musician. My dad tried to take him to the OR. My brother hated it. So it's just yeah, two different personalities, two different callings, and I just love surgery. I just loved what my dad was doing. I would like peek over his shoulder and be like, "What are you doing?" And he would tell me things, and I don't remember what he would say, but I just found it fascinating.
Yeah.
Very, very cool.
That's an amazing influence and story. So how long has he been retired now?
A very long time. I feel like maybe 10 plus, probably about 15 years.
Yeah.
Yeah.
Wow. Well, that must have been a hard transition just for him, I
It
think.
was. He always tells me that he's like, "Lori, I retired too early." He was like, he said after he retired, he would still dream about surgery, but
Wow.
he's also the type. Well, first of all, my mom said, because my dad was traveling a lot, and my mom said, gave him an ultimatum and said, either you stop traveling or you retire from surgery. And my dad loved to travel, and like he would lecture and stuff like that. So he decided to just give up his practice. But yes, I think it was a very difficult transition for him.
Yeah, yeah, it must be being such a big part of what he identified with,
Yeah.
and loved. Yeah.
Yeah.
So, I guess we really answered this question already, but there's always like lingering thoughts, after you do an interview and then afterwards you're like, darn it, I should have said this. Um, so I wanted to revisit back one more time about what you want people to know about finding the best care for excision surgery. Like, what are the green flags? And you might decide to talk about yellow or red flags too, but what are some of the green flags with finding a good surgeon?
Green flags. Well, I mean, there's some, like we mentioned, some questions to ask your surgeon, but I think one of the biggest things is, do you do excision or ablation? I think that's a huge question to
Huge.
ask. That's definitely a green flag if they do excision, ablation. I think if your surgeon is doing ablation, maybe get a second opinion with a surgeon that
Mm-hmm.
does excision, because that really is the gold standard for endometriosis treatment and also for the surgical procedure. The other thing too that I tell my patients, because a lot of my patients, speaking of second opinion, I tell my patients get second opinion. A lot of times I'm a second, third, fourth opinion for patients, and a lot of times they've seen really, really good surgeons, excision surgeons, and they rattle off these names. I'm like, oh yeah, these guys are good. These guys, gals, whatever. These doctors, these surgeons are good. You would be in very good hands no matter which surgeon you went to. At the end of the day, though, I think a big part of how to choose a surgeon after they've hit all the criteria. You have your pros and your cons list. They check all the boxes. At the end of the day, you have to choose your surgeon on who you feel the most comfortable with, because you as a patient, you're asleep. You have no control of what's going, which is terrifying, terrifying. And so you have to have surgery by a surgeon who you feel is going to take the best care of you, and also who you feel the most comfortable with. And if all things are being equal, I feel like you should trust your gut. And it doesn't matter how many papers they published, how many awards they've gotten. If you don't feel comfortable with the surgeon, even though they check all the boxes, it may not be the right fit. I don't know. That's what I tell my patients. I'm like, look, you'd be in the best of hands with all these five surgeons that you've seen. They're amazing. I know them personally. I know their work. And at the end of the day, and patients will say, well, how do I choose? I said, you have to choose on based on who you feel the most comfortable with, who you feel like is going to be your advocate when you're asleep, and do the best thing, do the next best thing for you, do the right thing, do the best that they can do. And I think a lot of it, you have to trust your gut, which sounds kind of silly when you're choosing a surgeon, but at the end of the day, I think you really do have to trust your gut after you check off
Yeah.
certain criteria,
Yeah.
right?
Yeah. Yeah. Definitely. Because there are a lot of incredible surgeons sprinkled throughout the U.S. We can't say there's a lot, but there are incredible excision surgeons across the U.S. that would do a great job. So if we think about and feel the experience of the profile, the life kind of journey, the walk that a patient with endometriosis has had, they have experienced a lot of crap, a lot of medical gaslighting. I can't remember the psychologist who coined the phrase institutional betrayal,
Mm,
but it seems a very appropriate term to use, because we go into healthcare thinking, well, these are the experts. No matter who you see, healthcare, they're all experts, right? They train for
right.
this, but then they get betrayed inside that system when someone says, oh, it's just period pain,
Yeah,
or we're not going to do anything unless you want to have kids, and then we'll listen to you because it's
sure.
about fertility or something like that. So at the end of the day, since this disease really is a disease, although males could get that, it's incredibly rare. It's mostly a disease that females are going to have. Safe to say there's been a lot of medical misogyny and the gaslighting that they've experienced, um, eh, because you're female, because of your personal experience, and just being female means we're already going to have to like work harder, um, sometimes in uncomfortable clothes and heels and stuff, to get to where the same place to where men would get. So do you feel like that you've experienced, or your patients, just as a stories of solidarity that your patients or you have experienced in your pursuit of becoming a surgeon of where you are today? How have you handled those things along the way, and what advice do you have to give to your patients when they have experienced something like medical misogyny?
I guess the only advice I would have is be unapologetic, be annoying. You know,
Mm.
I don't take no for an answer if you feel like it's, if I mean, sometimes, yeah, you have to take no for an answer, but there's always a second opinion. And I don't recommend, I'm not saying you should just keep on going from doctor and doctor shopping and all that. But if something doesn't sit right with you, there's, you may have gotten the wrong answer from an expert. You could have gotten the right answer from an expert, and it may not even be an expert that you were talking to. I think in this day and age, there's a lot of, I mean, I don't necessarily recommend that you're like Googling and everything like that, but there's a lot of information that patients have access to that they didn't have 5, 10 years ago about endometriosis. And again, you were talking about support systems. I think there's tons of support groups now for patients specifically with endometriosis, online, in person. Reddit, I guess, is a huge thing. Social media is a huge
Yeah,
source of information. There's a
one of
lot
the
of
rare,
misinformation out there, but
true. Yeah.
at
One
the
of the,
same time,
yeah. Oh, one of the rare positives of social media, right? is the support groups that are out there, which is
yeah,
true. Yeah.
yeah. So I don't want to say be annoying, but like be unapologetic. That's a better word. Be unapologetic and don't be bullied into just not asking questions. If something doesn't make sense, ask questions. And this is your body. This is
Yeah.
your life. This is your life. So no one's going to take better care of you than you are. And you have to, I mean, think about how you would take care of a loved one. I mean, you would, I have children, and I would do anything for them. And if someone slammed the door in my face with one of my kids, I just go down, down to the next door, and hopefully it's open, and just keep on knocking on doors. We don't give ourselves the same compassion and care that we give our loved ones. And so that's why I'm just like, be apologetic. Just keep on asking questions. Don't take no for an answer, and educate yourself.
Yeah. Yeah. It's so true about what you said. I want to revisit that for just a second about how we don't advocate for ourselves as strongly as we would as, say, if it was, I know, I have 3 kids, if it was one of my kids, and trying to get a diagnosis for them, because goodness knows, my kids are all teenaged in years now. They're all teenagers, and which is that's a whole other podcast. Self is trying to mother teenagers, but that's, over 20 years times 3 of advocacy. And if I think about, did I advocate for myself with the same fierceness that I advocated for them when they had special needs? I
Probably
don't think
not.
I did,
Probably not.
because the pain that women go through with menstrual cycles, and because no one really talks about it. And previously, our mothers and especially our grandmothers never talked about anything, nor was there any care for it, really.
Hmm.
Meant that we just normalized pretty much everything, that had to do with female anatomy and physiology, which is sad. So I want everybody to take Dr. Lou's advice to heart. Yeah, be assertive, be annoying, and don't back down. Trust yourself.
Yeah.
Yeah,
Yeah.
trust yourself. So has it been hard? I don't know how to phrase it. Succeeding, as because we don't the reason it's hard for me to phrase it is because I feel like in a lot of interviews women get asked questions that men don't, right? And now it can be frivolous, like someone asking Michelle Obama what she's wearing, and she's like, "Who cares what I'm wearing? It's just the work I'm doing, right?" So
Yeah.
there's that frivolity of kind of, I guess, misogyny and marginalization that women get. But I think the question that I always want to ask women who succeed at such, like, doing incredible things like you're doing, is because we want to see women doing what we would aspire to. And 2 generations ago, that was really hard to find. A generation ago, still really hard to find. it's less difficult to find today, but it doesn't mean that you didn't have unique circumstances that still felt like more of a struggle. Like, boys expecting to achieve, and they would be the ones to go to med school 100 years ago, 30 years ago, 50 years ago, whatever, instead of you going to med school,
Yeah.
right? So
Yeah.
has there been, what have you felt, what's been the hardest part about succeeding as a woman in your field? Because, and just for all the listeners, I want to say we don't have to ask men this because the path is already well paved to
Yes.
facilitate their success. So we still have to talk about it because it is harder.
Yeah. And to your point, I mean, I don't think really men are asked in interviews about their work family balance. How do you
Never.
balance family and work? No,
Yeah,
there's no questions like that.
because they
Women, we
don't
get
they
asked
don't
that all
have
the
to.
time. Yeah, exactly. It's like, oh, well, my wife takes care of it.
Right? They've got a wife.
Um,
I don't have a wife.
I
Maybe
know.
I should get one.
I tell my husband all the time, who's a PT, by the way, I tell him I need a
Oh my
wife.
gosh.
I need a
Yeah.
wife. Can you
Yeah.
find me a wife?
Mm-hmm.
But no, there are so many more challenges I think that women face when they have a career, as well as family, as well as I think just life in general. I think we have to. There's so many more hurdles for us to cross in order to get to the same finish line as men. I'm not saying that men have it easy. They have their own challenges, obviously, but particularly women, I think in the workforce, obviously there's many. I think everyone can agree that there's many more hurdles that we have to jump through, and hoops that we
Yeah.
have to jump through in order to get to the same place as men.
Yeah. I think one of your stories that you were telling me, maybe you can share a little bit about this with the listener before we press record, was when you were nursing, like, and trying to, like, you're working right up until, and then you're
Yeah,
you're right back in the OR.
yeah. Yeah, no, I have two children. I worked all the way up. I mean, I delivered my second baby on a Tuesday. I operated on a Monday, and then the next day I went in
Like,
for my scheduled C-section, which was the second
gosh.
one. And then I breastfed. I nursed both of my children, and I went back to work 4 weeks after my C-section for the first one, and then 5 weeks after my second one, I went back to work. And so I was nursing, I was pumping,
Oh my gosh.
and in the OR. It actually wasn't. Thank you to all of the women who paved this road for us working mothers, because I just, when you say unapologetic, when I tell patients to be unapologetic, I was completely unapologetic. I would pump while I was operating. I think I told you before, I think everyone in the OR has seen my boobs, men, female. I didn't care. I was like, if you don't want to see my boobs, then turn around. I got to connect myself to the pumps, and I'm going to
Yeah.
keep on operating. The
Yeah.
nurses would run my breast milk back to the fridge. Everyone is very accommodating, but I didn't give anyone a choice to not accommodate me. I was just like,
Mhm.
this is what I'm doing. I'm unapologetic about it. If you don't like it, then complain. But this, I'm sorry. I'm not gonna change this. But I was very fortunate. I'm very fortunate because I'm surrounded by a great team. I'm surrounded by great mentors who are male, who support me, and as well as females as well. And like I said, thank you to all of the working mothers 10, 15, 20, 30, 40 years ago who didn't have the luxury that I had to just kind of, hey, I'm pumping and I'm going to,
Yeah.
2 minute break while I like hook myself up to the pumps and I'm going to continue operating. And I think even to this day that not a lot of surgeons have, or a lot of trainees, residents, surgeons, students, they don't have that luxury that I do now
Mhm.
that I'm an attending surgeon and it's quote unquote my OR. I don't
Mhm.
know if I was in training or if I was a student, if I'd be able to do that.
Mhm.
So I think we still have a long ways to go. But again, be unapologetic. This is what's happening. This is the best. This is what's best for my family and for myself. And I got to feed my baby. And get over it. If you don't want to see, then turn around. Like, don't look.
It gives new meaning to the or kind of underscores the phrase of, it takes a village, with the nurses running the, the
It
milk back and forth,
does.
and yeah, to the fridge and stuff. Because it does take a lot of people, and I this is so resonates with me when you're talking about the support systems that you need, because yeah, as women in healthcare, in in medicine, in various areas of caregiving people, it takes so many people to help that, to bring that together, whether it's one kid or three kids, or whatever you have. But it you can't do it alone, that's for
No,
sure.
definitely not.
And so that means, for everyone listening, that ability to push back when you experience medical gaslighting, when you experienced snarky comments that sound like, misogynistic comments, just belittling or marginalizing the type of pain you have because it might be related to female parts, air quotes, for those of you not watching on YouTube. Um, and the very experience of endometriosis itself is exhausting for women. It's very fatiguing. So is there any advice that you have, or maybe what it's just even how you approach them when they come in and you're doing consults, to just acknowledge that fatigue, that they've stood up for themselves enough that they got to your office, right? They found you, they're in your office. That alone is a huge win. It's a big victory. How do you then set the stage for them in terms of, because they may not have the energy, to like keep pushing back and to keep feeling like they're on top of it. And then again, they can gaslight themselves again, because they're like, I should have the energy to keep going and keep leaning in and keep pushing back, that kind of thing. So when they make it to your office and they've got that kind of universal look of, this is exhausting, I'm so tired, what happens? Talk us through, or just walk us through that experience, when they come in for consult.
Yeah, most of the time I just try to let the patient talk, because I think a lot of times patients are talked at and not just listened to. And
Yes.
honestly, if you just listen to the patient tell their story for the first 5, 6, 7 minutes, by the sometimes I interrupt them, and be like, we've been talking for 2.5 minutes and you've hit every single major symptom of endometriosis. I cannot believe that no one's ever mentioned this to you,
Yeah.
and that you're self-referred, that they were just Googling their symptoms. Oh, maybe I have endometriosis. I don't know. I feel like I feel like we just don't listen to the patient. If you listen to the patient, they will tell you what's going on, because as a patient, or as a person, you know your body better than anyone else, right? You live in your body 24/7. And I, like you said, you're so tired because you've been trying to say what's going on, but you're completely dismissed time and time and time again. It takes an average of 7 to 10 years to get diagnosed with endometriosis.
Mm-hmm.
So can you know something's wrong, but a decade later, no one believes you still. So of course you're exhausted. It's like, why am I fighting? I keep on banging my head into a brick wall, basically, because I'm
Mm-hmm.
told the same thing over and over again. And then you start to think, oh, well, maybe I'm actually not feeling this. Maybe I'm actually just crazy. But,
Mm-hmm.
like I said, you know your body better than anyone else. Um, don't you dare let a doctor who, no matter how fancy their degrees are, who's met you for 5 or 10 minutes, tell you that there's nothing wrong. They don't like that. Sure, you may not have endometriosis, you may not have X, Y, and Z, but I feel like the patient needs to be validated, they need to be believed, and just listened to. And
Mm-hmm.
that's where I try to just, at the very beginning of of a consult, I'm just like, so tell me what's going on.
Mm-hmm.
What brought you here? And the patients usually just start talking, and I'm taking notes, and I'm like, this is classic endo. Like, They've had like 3 colonoscopies, 5 cystoscopies. They're on all these different types of like medication for anxiety. Yeah, no shit, you're anxious
Yeah.
because you completely like this has been going on since you were 11 when you started your period, and now you're 30 and you're trying to get pregnant. And yeah, I could talk about this for days, but I think really validation, listening, and just believing that what the patient is feeling is truly what is going on. Now, like I said, I don't know whether she has endometriosis, or I don't know whether the patient has endometriosis or not. There's no way, I don't have a crystal ball without taking a look inside, but at the very minimum, I mean, yeah, I believe that you have left leg pain and it's difficult for you to walk during your periods. I believe that you don't eat all day during your period because it hurts so bad to poop. I 100% believe you. I believe you that, I mean, the list can go on and on. I
Mm-hmm.
believe that. I mean, why would the patient make that up? Why would she starve herself all day during her periods just so she doesn't have to poop for those couple of days? I mean, it's
Yeah.
I don't know. I just think I think doctors just don't listen enough. And
Yeah.
also that's a reflection of how healthcare is today, though, because first of all,
Mm-hmm.
you're expected to see like 50 patients a day because you don't get any reimbursement by the insurance company. You have to
Yeah.
document every little single thing, otherwise
Mm-hmm.
you don't get reimbursed by insurance companies. And at the end of the day, I'm sorry, there's no time to listen to the patient, because
Yeah.
all you need to do is you just have to order ultrasound, blood work, and an MRI. It's negative, you're fine. You're fine. Oh, your
Mm-hmm.
periods are bad. Here's some birth control pills. Oh, you tried here, try a different type, and contact me in 6 months. Give it 6 months and then come
Yeah.
back. That's another 6. No wonder it takes 7 to 10 years to get diagnosed.
Yeah.
Because you're just, let's just kick this can down the field a little bit more. Let's play hot potato. Go see a GI. Go see a urologist.
Mm-hmm.
I don't even remember what the original question was, Dr. Carter, but you like, no, but this is
The-
like, it's insane.
you actually just segued beautifully into my last question, because we started out talking about just providing that support and reinforcement and validation that patients need when they come in, and their proverbial can, that whole medical record, them being just a code or a diagnosis or a lack of diagnosis to a practitioner or the insurance company, just gets kicked down the road a little bit. So we started out talking about that and how that validation is so important. But then it morphed into my last question, which is, it's a difficult one, but it's one we have to kind of face head on in the United States, particularly right now, because given our current political climate, which is just feeding uncertainty, um, and healthcare access for women, how does that, how do you see, none of us can predict anything, right? But how do you see that things will shift or be impacted, or how are you, I guess, providing that reinforcement or um, uh, support and care for your patients who come in worried about those things, since in general, it's going to be increasingly harder to access healthcare, and we're not sure what's going to happen with the research budget. And when we only got 0.038% of the NIH budget anyway, what's going to happen? There's probably things that you're looking to in terms of advancement, like things you can get excited about endometriosis for the future. Maybe um, less invasive, diagnostic possibilities. But also, what do you see as concerns to tackle for the future? So it's kind of a two-part thing. One is pro, like, what do you see in the future? What would you like to see happen in the future? But then part two is really what, or we can switch them out either way. What are the realistic challenges that we're facing ahead?
What would I like to see in the future when it comes to endometriosis? I would like a lot of things, but I think
Like a
the
Christmas, big
biggest
Christmas list.
no, I think a big thing, because I think a big thing that I would like is for anyone who who has certain symptoms to be, and I mean, this is completely just, but I wish there were more. First of all, I wish there were more excision surgeons, right? I wish
Yeah.
there were more people who just specialized only in endometriosis and did excision surgery. I wish that was just completely, I wish there was just a million of us in the United States, and we'd still be completely busy because there's so many patients who need it. But I wish that it was more, I wish it was like an ACOG or our governing body as OBGYNs, that anyone with certain symptoms, we love flowcharts in medicine. We love algorithms. We love
Hmm.
this, if yes, then here, if no, here. And then we just love that, right? Because
Hmm.
it makes things very simple for us. I wish that referral to a specialist was more, was more common, especially for OBGYNs, generalists. I don't get a lot of referrals from OBGYNs, to be honest. I get a lot of referrals from PTs. I would say the most common people who refer to me are pelvic floor physical therapists, which are amazing, as well as gastroenterologists, which is,
Mm.
but when it comes to regular OBGYNs, no, not a lot, which
It
I
says a
think is
lot.
very strange. I
Yeah.
really think it's strange. So I wish there was something like that, that ACOG will put out an announcement saying, look, if patient has blah, 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 endometriosis should be at the top of your list when it comes to differential diagnosis rather than at the very bottom, which it always is. Endometriosis is
Hmm.
always the last stop on the train, always. And they've gotten
Hmm.
$1 million workup by every single other specialist
Hmm.
before anyone's like, huh, maybe it's endometriosis, or worse yet, no one's even mentioned that to them. The
Yeah.
patients have found it on Instagram. Oh, that's
Hmm.
that, like it's anyway. So that's one of my biggest things, and I think it's a pretty simple change that could a pretty simple thing that could change, just it could change so
Yeah.
many people's lives. It just with that one simple statement, just say consider endometriosis should be at the very top of the list. Other things, I know they're working on a lot of diagnostic tests or screening tests, saliva tests, menstrual effluent tests, stuff like that to screen for endometriosis. I think that's great, but also I think if you just ask certain questions to patients and you screen them that way, a lot of times, if a lot of times they'll answer, and a lot of times that points you in the direction of endometriosis. I think imaging, MRI, endo mapping, ultrasound, I think all of that is really coming. I think Europe is way ahead of us when it comes to that. But I think that's going to become more of a global screening method. But then again, a lot of time, but then there's not a lot of practitioners who are very good at it. And again, you have to have a specialist do these special types of imaging tests.
Hmm.
So honestly, I just think that it would be good if we could just get endometriosis to the top of differential diagnosis when it comes to pelvic pain, unexplained infertility, as well as painful menstrual cycles, bowel with any of that, I think endometriosis should be at the top of the list. And then not just say, you probably have endometriosis, let's put you on birth control pills or X, Y, and Z. They should be referred to specialists.
Yeah. Absolutely. That's such a good point because a lot of the times, and I ask this question often, what do you see as the future of an endo? And it's always related to diagnostics, better diagnostics, easier access, more surgeons. But having an algorithm like that or an inventory would be so helpful. So
Yeah.
helpful. So, any other challenges or that you see or ways in which we could, I guess, the appropriate term would be to push back against the things that we're going to see in the near future in terms of research and access to care. Um, any words of wisdom on that you could leave us with?
Yeah, I mean, there's not a lot that we can do to control our surroundings or
Mm-hmm.
this government's going to do or what laws are passed. I mean, yeah, we can go out and vote, but at the end of the day, there's not a lot of control that I have over really anybody else except for me. And so I think what I always try to do, because I'm such a control freak, I want to control my kids, I want to control my husband, I want to control everybody, but I can't, right? I only have control over me. So when things around me are not going the way that I want, I have to remind myself, first of all, I have no control over the situation. I only have control over how I react. And how I choose to react is sometimes very inappropriate. You can ask my husband, I have a big temper, which doesn't come out a lot, but if you push me, it comes out. So sometimes I react inappropriately, but I always do try to do the next best thing. And I think that's all we can do as individuals is do the next best thing. And then also surround yourself with like-minded people because you need support. We all need support. No one's an island. And so I surround myself with like-minded surgeons. I surround myself with supportive family, with supportive friends who kind of some of them are surgeons, some of them aren't, but surround yourself with support and then just try to do the next best thing, because that's really the only thing you have control over is your actions and your reaction. And but we're all human. Sometimes it's not easy to do the next best thing, but I think if we can try to just strive for that, and if everyone does that, then I think the world actually would be a better place, despite our surroundings that can crumble around us. But at least we will be okay with ourselves. And because really, if that's the only person you have to be okay with is yourself.
Yeah. Let's sage perennial wisdom, like for everything, right? Not just endometriosis. Um, so if you're feeling that frustration and fatigue and a bit of that trauma posturing with those tissue issues that we were talking about, know that there is help, there is support, there are plenty of healthcare providers across the interdisciplinary spectrum that believe you and want to see you be better. So don't give up. You are cared for, and we care. And to that end, Dr. Liu, can you tell us where to find you?
Yeah, you can find me on Instagram. My handle is at Dr. Liu underscore endometriosis underscore surgeon. I am also on TikTok while
Hmm.
it lasts. It's at Dr. Liu underscore endo underscore surgeon. And then also my website is www.loraliumd.com.
Thank you. Thank you so much for giving us that unique perspective, um, which is so important for, oh my gosh, for women who are experiencing this. I've heard of more than one story of young girls, young women who go through the experience of endometriosis surgery and recovery and are so moved by that that they actually want to go into the medical field
Yeah.
as a result. So that story that you've just so generously shared with us is inspiring to someone that's going to hear it, that may make up another and add another excision surgeon, to the list of providers, or provider in another way, because there's just not enough to go around for sure. But thank you again for joining me today and for sharing your story. I really appreciate it.